Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research based information about cancers and their treatments. Hi, I'm your host, Dr. Prasadraj. I'm the head of radiation oncology at Sir H.N. Reliance Foundation Hospital. And today we are going to talk about something very interesting on robotic surgery. Now, this is something that keeps coming up all the time in conversations, and robotics and AI has become such a buzzword now. Like just the other day, I was seeing a patient who is from Kolkata, and she was operated in Kolkata by a gynecologist for bleeding from vagina, and they found a cancer. And they came to me for advice asking, doctor, should we have done a robotic surgery? I realized that the patient actually sort of didn't know much about the robotic surgery, but they had heard about it and they were curious about it. So today we have an excellent person to talk about robotic surgery with us. We have Dr. Imran Hamzawala with us. He's the head of robotic surgery at Saifi Hospital in Mumbai, and he's also a national proctor for gynae oncology and robotic surgery. Welcome, Dr. Imran, and it's such a pleasure to have you on the podcast.
Thank you so much, Prasad, and it's a very nice introduction. I appreciate that.
Yeah. And Imran, I remember I think many years ago, I got a call from Dr. Kamran Khan, and he said, Prasad, I need to introduce you to this fantastic guy who has just come back from UK. You are going to love working with him. And that's when we met for lunch, and it's been a great pleasure to work with you.
Yeah.
So how did you sort of decide to go to UK and become a specialist in robotic surgery back then when robotic surgery was not even such a buzzword?
Yeah, I mean, my journey is a pretty long one, Prasad. But I'll try and shorten it as much as I can for our viewers. So I did my MBBS from Grand Medical College Sir JJ Group of Hospitals, and then I decided that I wanted to go to the place where all that medical knowledge had come from. I really enjoyed reading UK textbooks more than the US textbooks, I might say. So which is the reason why I was one of those who decided to move to the UK to get my postgraduate education. So I went there, got my postgraduate education, which is MRCOG, which is member of Royal College of Obstetricians and Gynecologists. And then I decided I wanted to do something more. I wanted to super specialize. So I decided that I wanted to super specialize in a field of gynecology which is very dear to my heart, which is gynec-oncology. And as a part of it, I was fortunate enough, Prasad, to be exposed to robotic surgery. And it just so happened that when I landed there as a junior at first, and then became a senior fellow there, that they had invested in the Da Vinci robot. I was fortunate enough to start there and get into the nitty-gritty of things. Start with the robotics program with my consultant colleagues at the time, and then eventually learned more and more and more. So my experience in robotically assisted surgery spanned over a period of about 7 years in UK before I moved to India about 8.5, 9 years ago now. So about 16 years worth of robotic surgical experience there. What ultimately matters is whenever you embark on a new technology, what we are really interested in is good patient outcomes. And when you look at good patient outcomes, it's not just about, as you know, Prasad, it's no longer about just removing the oncological tumor. It's about improving the quality of life, or rather getting the quality of life back to what it was. In inverted commas, I like to call it functional outcomes. So surgery is, taking out the tumor is a given, Prasad. We do that with open surgery. But when these technologies started coming into play and when they were allowing us to get good functional outcomes, that's what got me really excited in the UK. And I got that excitement all over here in India, and I'm still doing a lot of that.
No, aren't we glad for that? I mean, it's been amazing to see the work that you're doing with the robot and how you are sort of mentoring so many surgeons and helping them to sharpen their tools as well. Let's talk about the journey. Like I remember when I was doing my MBBS in Sion Hospital back in the days, one of our surgeons who was so keen, he would tell us that good exposure is the key to a good surgery. You need to open it properly. If I don't see it, I can't cut it. And these were the days when you had open surgeries, big scars, infections, and wounds not healing, the scars having hernias and all of those. And now for patients it gets confusing because they feel, oh, instead of big scar, you're going to give me a tiny scar. How are you going to do this surgery? So what's been this evolution? It's almost like a paradigm shift for surgeons to say, I don't want a big opening, I want a small opening. What's happening here?
Yeah. So that's a very good question, Prasad, because a human being as such is a funny being. Why? Because we want change for the betterment of mankind, but at the same time we are also resistant to change. So what happened initially in let's look at the history of surgery. You had open surgery, which was considered as the gold standard for any operative intervention in the past. As you rightly said, that the exposure, we want to open up big scars, big surgeons, open up, see everything, because the whole idea of open surgery, which I want to let the audiences know, is that you need a bigger scar to get your hands inside, Prasad, so that you can do the job right. So because if you can't get your hands inside, you can't remove the problem. So that's where open surgery was. But at the time in the past, open surgery was all about, key issues, which was life-saving issues. We've moved on from life-saving, which is a given, but at the same time, we are focusing on more functional outcomes, as I dwelt to in the past. So when we look at functional outcomes, is the person able to jog again? Is the patient able to play golf again? Is the patient happy to jump around with his kids again or her kids again? So all of this is become very, very important in today's world. So when laparoscopy came back, as you remember, Prasad, in the past, it was treated with absolute scorn. People said, oh, this is a technology which is never going to fly. And we are sitting here right now in 2025, where it's almost, you can't even imagine, Prasad, where a patient just comes to you and says, Doctor Saab, kya ye procedure, can it be done via the minimally invasive route? Can we do it? Durbin se ho sakega? That's the simple question that patients ask. And rightly so. Why is that? Is because there's lesser blood loss, there is quicker recovery. All of this adds value. So the idea of the robot that has come into play is purely to make life easier for the surgeons, and give them the tools to do a better job for their patients. And I'm sure through the talk we will elaborate a lot on that.
Yeah. So why don't we first get into the paradigm shift that happened from open to laparoscopy? Like what happened? What is laparoscopic surgery?
Okay. So laparoscopic surgery is basically minimally invasive surgery, which means we don't want to make big cuts. We just want to have very tiny cuts in any particular part of the body where laparoscopy is being done. Because I'm a gynecologist and a gynec oncosurgeon, I will talk about cuts on the tummy. Whereas a thoracic surgeon, which is a chest surgeon, will talk about cuts in the thorax. So very small cuts which allow certain instruments to go in, known as cannula, which are channels. And through these channels, these specific instruments can go in. Now, what happens is that when the instruments go in, the person needs vision. So we need a channel for the camera to go in as well. And what the surgeon used to do in laparoscopic surgery, it's different in robotic surgery now, but in laparoscopic surgery, we would operate using our hands and these instruments through these channels, but we would be looking up and looking at a screen whilst operating. So it's amazing as how, Prasad, I want to say as to how the human mind can adapt. Because when you're doing open surgery, Prasad, you have the benefit of two eyes. So you're seeing your vision in 3D, technically. But when you're seeing it on a screen, you're seeing it 2D. So the human mind adapted and said, okay, I'm going to do, this surgery just looking at a flat screen. And they don't have that 3D perception, but still they were able to do a job. Also, I might want to add something. I don't know whether you can see this, Prasad. Can you see this here? So the instrument has gone in, okay? Now, if I want to move the instrument on one side, on the outside, the instrument moves on the opposite side. If I want to move the instrument on this side, On the outside, the instrument moves on the opposite side. So what we are trying to say is that the human mind was so brilliant that even with counterintuitive movements, we are able to perform the operations and the complex operations to achieve good outcomes. And that was laparoscopy. So just veering off to your previous question, the reason why the robot came in is because it wanted to sort of fine tune these things to make life easier. So when I get my vision with the robot, it's high definition, it's three-dimensional, and it's 10 times magnified. So I can see better than my normal eyes can see. That's number one. Number two, in robotic surgery, when I move my right hand, Prasad, to the right side, the instruments move to the right side. When I move it to the left side, the instruments move to the left side. So the movements are not counterintuitive, they are very intuitive movements. So they've ironed out perhaps the problems that laparoscopy has and made it into a better platform to do minimally invasive surgery.
So that's amazing. I mean, I'm sort of, I'm a radiation oncologist. I'm thinking from that point of view. Like in our case, we had the two-dimensional radiotherapy, then IMRT came, and now we have adaptive radiotherapy. And it has been an evolution, because we had IMRT, IJRT, we are able to move into the adaptive radiotherapy realm now. And with the robot, the technology has actually made surgeons' life easy, as you said, which will translate into patients benefiting from it. And we've heard so much about this Da Vinci robot, and but most people wonder. I have had patients ask me questions like, if the robot is operating, what if the electricity fails and the robot, stops working, or what if the robot, like we all see all these sci-fi movies. What if the robot goes rogue and he sort of cuts me open in a way that I don't want to be cut open?
Yeah.
So, how does that work? What is this robot?
Okay, so it's a brilliant piece of tech. That's number one. At least you had a very kinder question that was asked, where you said something to the effect that what if the robot malfunctions? That's a kinder question. The question that I got asked in my clinic, Prasad, was, Doctor Saab, अगर robot operate करेगा तो आप क्या करोगे? so 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 it's but what I want to tell our viewers is the bottom line is that the robot is not autonomous, Prasad. It cannot move a single millimeter without the consent of the surgeon. Okay, so to sort of break this down, now let me ask that very pertinent question that you asked: is it safe? Well, undoubtedly it is safe. Over more than 10 million procedures worldwide have been done using the robot. And what I'm trying to say is that there has never been a serious issue on account of the machine. And there is a reason why. The reason is that the machine does 6,000 calculations per second. And if any of those calculations is not quite right, it will flag up an error and the instruments will freeze. And there are so many fail-safe mechanisms that are in place. If this fails, then this one. If that fails, then that one. So the system is very, very cleverly designed, and it's foolproof, which is the reason why you can imagine that it stood the test of time for over 25 years. Now, obviously, if there was any problem with any patient in terms of the system causing a huge problem, that would have been the end of the company. But the fact is that, it's still moving on and it's going on all guns. It's testament to the fact it's an engineering marvel, in my opinion. That's number one. Now, let's break down the robot a little bit, Prasad. When I walk into my operating theater, which is my second home, there are three components to the robot, Prasad. One is a patient cart. We are going to call it patient cart, which is actually the robot which attaches to the patient, hence the name patient cart. It looks like Optimus Prime. It's got all its arms to attach to the patient.
It looks very scary for me. I mean, when I saw it for the first time, I said, "My God, all these arms! It looks
Yeah.
like a spider who sort of
Yeah.
sit on you."
No. But believe me, it is a gentle giant, Prasad. It is a gentle giant. So that's the patient cart. The second component, Prasad, is known as the vision cart. Now, the vision cart is where there is a dedicated screen attached to that cart. And the reason why it's known as the vision cart is because that screen allows us to see what is going on when the surgeon is operating inside the patient's body cavity. When the surgeon is operating, we can see all of that, hence the name vision cart. But they've made that vision cart very clever, Prasad, because it's also a telestration device, and allow me to explain that, which means that when the surgery is live happening on that screen, which we can see what the surgeon is doing, let's assume I'm a mentor, which I am, as you mentioned, the national proctor. So when I travel across to different cities to train or mentor people in doing robotic surgery, that telestration screen allows me to draw things on it, which the surgeon can see when he or she is sitting on the surgeon's console. So that's amazing, because what I draw here, it can easily be appreciated by the surgeon who is sitting on the console. So by default, that acts as a training tool. So which means that when I go there as a mentor, I can say, okay, why don't you let go of this and try and hold this to help that? And I can draw that, and the surgeon can immediately appreciate that. So coming back to the final and the most important part of the robot where the magic happens is something known as the surgeon's console, Prasad. Now, the surgeon's console is where the surgeon is actually sitting down. His or her sort of arms are very beautifully rested. They're not like this in laparoscopic surgery. Imagine doing laparoscopic surgery with your arms up for so many hours. It ultimately will take a toll on your shoulders. Whereas in robotic surgery, you're operating nice and comfortably. And your fingers are inside something which is what we call as master controllers, Prasad. So whatever movements I make with the master controllers are replicated on the robot, on the patient. So, and what's interesting also, if I may add, is that if you look at any human being has got an element of tremor. So, there's an intentional tremor that exists with every human being. Perhaps.
So when you say tremor, that little shaking of hands that we may have.
Yeah. So that little shake that exists with anyone. If you put your hand out, you will always find that little bit of shake. Perhaps someone with a steady hand has less shake, and someone with less steady hand more shaking. Now you might think that, oh my God, you've got the power of instruments with these master controllers in your hand. What's going to happen with all that shaking? The beauty is that the robot has an inbuilt thing known as tremor filtration, which means it filters out all the shaking, all the tremors, and it only mimics gross movements.
It's fantastic. I mean, the technology is really changing so many things for patients and the doctors. But, the common question that comes is, okay, you have a robot, then why not use it for every surgery? And then the surgeons say, no, you can't use it for every surgery. There are select surgeries. So what are those surgeries where our patients will actually benefit from it? I mean, I'll give you an example. I had a patient who came to me, this is, I think, 4 or 5 months ago. And then they said, I need to have my breast surgery done. She had a very small little tumor. And some surgeon had recommended a robotic breast surgery. And my question in my mind was, is that really going to help? Is that really going to change the outcome for the patients? Because the breast surgeries are sort of related. So what are those indications where we can actually use robotic surgery with an positive impact on the patient?
I think the key point that you raised, Prasad, was a positive impact. I think that's the key. So let's talk about robotic surgery per se. Now when we do robotic surgery, Prasad, and I know that unfortunately we incur an additional cost because there is the equipment that comes from the US. I don't know whether we've mentioned this, but the robotic system, which is Da Vinci, is the name of the robot, but the company's name is Intuitive Surgical, which is based in the USA, and it is the biggest and largest company which provides robots all across the world. So the robot that I'm operating right now at, say, Saifi Hospital or Reliance Hospital, anywhere, is the same robot that I was operating with in the UK. So there's no difference in the robots. That's the bottom line. So So what I'm trying to get to is that because the equipment comes from abroad, obviously, unfortunately, the patients have to incur an additional charge or an additional cost, on account of using the robotic technology.
Yeah.
So, in my humble professional opinion, or the way I see it, is that if I'm increasing the cost for the patient, it needs to add value, Prasad.
Yeah.
It needs to add value. So where will my robot shine? My robot will shine, Prasad, in complex work. So when it comes to complex surgeries, and I can give you multiple examples in terms of that, but in my field of gynecology and oncosurgery, we know that oncosurgeries are very critical surgeries. The surgeries are around very difficult structures. You're operating around the aorta, the inferior vena cava. These are big vessels which are present in your tummy that you operate on, and a single mistake can cause a catastrophic event, so when you're operating in such a high pressured environment, if I have the luxury of this technology to help me out and navigate through these difficult areas easily, then that is worth it, Prasad, because ultimately, if the patient recovers quickly on account of a minimally invasive approach, then that added value is what I'm trying to say. So if it's a simple surgery that can be done very conveniently and comfortably laparoscopically, then I'm not convinced that the robot is something that we probably ought to consider in those. But if there is a surgery which requires more finesse, more technical ability, then I think the robot shines in that spectrum. So an example, especially which is common between you and us, is a high-grade endometrial cancer. So if you have a high-grade endometrial cancer, like a serous adenocarcinoma, which is one of the types of high-grade endometrial cancer, Prasad, that just doing a radical hysterectomy doesn't do anything. We need to do a pelvic lymph node dissection, para-aortic lymph node dissection. We need to do an appendix. We need to remove the appendix, we need to remove the omentum. These are all the structures which need to be removed as a part of the staging procedure for these sort of operations. Conventionally, all of this was done open, Prasad, as you realize. That they've always been done open, to be fair. But when you do it open, the patient runs the risk of needing ICU admission for 2 days, and then probably a hospital stay in the ward for at least another 5 or 6 days before they go home. Now, when I do these surgeries robotically, my patient doesn't end up in ICU unless there are anesthetic concerns. And then 3 to 4 days maximum stay in the hospital, and they're home with hardly any pain. So when I have offered a better surgical outcome in a complex scenario, I truly added value to the additional cost that the patient had to incur with the robot. So I think that's what we need to sort of introspect. Also, I must add that it also matters what the patient wants at the core level. So which means that, there is radical neck dissections that happen for oncological malignancies, which are, mouth cancers and stuff where we do radical neck dissections. And the scar of the radical neck dissection is very visible, Prasad. So if someone is very keen not to have that scar, we could potentially make, small incision here, just at the hairline, get the robotic instruments through, finish the radical neck dissection, and come out. So, which means that the cosmetic part of the surgery is preserved. The surgical outcome is a given, but if the patient insists on a good cosmetic outcome, then certainly robotic surgery can be considered for those patients.
But Imran, that brings me to another interesting point. Like these, you mentioned about advanced endometrial cancers
Yes.
or head and neck cancers where we need neck dissections. Now, in a patient who has undergone an open surgery, for example,
Yes.
and they need radiation after that,
Yes.
the complications of combination of open surgery and radiation is much higher
Yes.
than robotic surgery and radiation, because what happens is when we do open surgery,
Yeah.
as you're aware, it creates a little bit of fibrosis or scarring inside.
Yes.
Radiation adds to that scarring.
Yeah.
But if the surgery is robotic, the scarring already is very minimal inside, and when we give radiation, that scarring is not enhanced.
Yeah.
So we are now time and again seeing, like, when I started my career, I remember we used to not very commonly, but frequently see patients who would land up with intestinal obstructions post surgery and radiation, because surgery has given them a lot of scarring and radiation is added on it, and
Yeah,
then the intestines get entangled in it and they have problems.
yeah,
Now, I really don't remember the last time I saw an intestinal obstruction in recent years, because most of our patients are getting robotic or laparoscopic surgery. So
yeah.
there's definitely a shift in how oncological outcomes are coming out. And the impact on the patient's life is not just immediate after surgery, but really long term, because they are going to need, sometimes chemotherapy, sometimes radiotherapy, and that I think is making a big impact. So, do you have any sort of did you have any patient where you sort of started with the robotic surgery and then you felt, oh God, I think I made a mistake. Maybe we should change something.
Uh,
Are there any situations? I mean, we spoke about the benefits of robotic surgery, but did the opposite happen sometimes?
so I think we've become smarter, Prasad, because it all. There is a very nice कहावत in Urdu. मैदान जंग में उतरने के पहले दुश्मन को जानना जरूरी है.
Yes.
So we have the luxury of preoperative imaging. So what I do is that I thoroughly investigate my patients first to see which candidate or which patient is suitable for a minimally invasive approach. Given that I'm an oncosurgeon, for ovarian cancer surgery, we do all surgeries open. We are not comfortable doing them robotically. But for endometrial cancers, I think it's a given that robot is definitely something that we need to embark on. We are also considering for very early ovarian cancers, if we pick them up, whether we can consider robotic, because if it's not spread, then why increases the morbidity where you can do exactly what we've done, via the minimally invasive route. So I think patient selection is very, very important in terms of, and making the right decision for your patient as a doctor is incredibly important. So you never land up in this scenario where you start off and you say, oh my God, why did I take this on? So I think the onus is on the doctor to make the right choice for their individual patient, and then decide it. Now, that is to say that especially when someone is starting off on their journey of robotic surgery, when I go as a mentor, when someone is starting off on their journey of robotic surgery, I always advise them, Prasad, to take on easier cases, to get the confidence under the belt, to understand the way the system works, and then you can start pushing the envelope. So we were thinking, we had a patient, Prasad, with an suspected endometrial malignancy, and that patient just, presented to me. She was a very fragile lady, but she had a very big problem in her chest. She had a medical condition known as interstitial lung disease. Interstitial lung disease is where the ability of the lungs to expand is no longer there. So they have very little reserve in terms of the breathing ability. And so I referred the patient to the chest physician. The chest physician said, absolute no, we cannot give her general anesthesia. And I said, why is that? The chest physician got back to me saying that if you put her on the ventilator, she's never going to come off it. That was the concern for that patient. So in the good old days, the only option that was available for us, Prasad, was to do spinal anesthesia, which is like an injection in the back, so that everything from here, bottom, till the bottom is all numb, and you can do an open midline cut to then do the procedure. But that's not helpful either. Why is that? Is because once the spinal effect wears off, the patient unfortunately has that open surgical wound. So they are struggling with the open surgical wound's pain. That's number one. And more importantly, when there is pain, you don't breathe effectively. So the lungs are already an issue. So all of those issues we're thinking, and we one fine day thought about it, saying that why don't we consider robotic surgery under spinal anesthesia? So what we did is that we counseled the patient and we said, look, we've not done this often. We really want to do this for you to give you the benefit of minimally invasive surgery. If we are able to pull it off, that would mean that you have no big cut. You'll be going home very, very soon. And that patient just went, yes, please. There was no question of her thinking any other way. She was absolutely okay with that plan. So again, robotic surgery is teamwork, Prasad. So it's not just about the surgeon. The surgeon may be the conductor of the operation, but the team that it revolves around it, which is the nursing staff, the OT theater staff, more importantly, my anesthetist, and also the technical staff, all of these people need to be in sync to make these complex cases happen. So we managed to give her the regional anesthesia, which is the injection at the back. She was numb. She was absolutely awake. We docked the robot. It was freaky, Prasad, to actually have the robot docked on a patient who was talking to me.
Yeah.
It was
And
insane
I'm
to
just
even.
imagining what she must be thinking, and
No, there was a
and
screen in between. There was a screen in between. She couldn't see it.
she
But
couldn't
what I'm
see it.
trying to
Yeah.
say is that I'm talking to her, Prasad, and she's been docked with the robot, and we are operating on her. And we managed to do the surgery. And the patient was walking in less than 16 hours after surgery. She went home in 2 days after surgery. Now, coming back to it as to why robotic surgery might be better than laparoscopic surgery, because one could argue, Prasad, well, we could do this laparoscopically also. Why not? Why robotically? Because, Prasad, what's important is that in order to do surgery, I want to explain to our audience, in order to do surgery, we have to fill the tummy up with some gas, Prasad. That's known as carbon dioxide gas. The carbon dioxide gas needs to be filled up in the tummy so that there is enough room for the instruments to go in and out.
So you're sort of creating space. You're like
Creating
creating a
space, yeah.
balloon instead
Yes,
of a deflated abdomen. You're
yes,
creating a balloon so that you
yes,
can
yes,
operate into it.
yes. So in conventional laparoscopic surgery, which is what we've talked about before, I need panoramic vision, which means I'm looking at everything from a distance. I'm looking at everything from a distance. So what happens is that because I'm looking at everything from a distance, I need more gas. So you know that when you fill the tummy up with gas, there is a partition which is there which separates your tummy from your chest, which is known as the diaphragm. So when you fill the tummy up with a lot of gas, the diaphragm gets pushed up. When the diaphragm gets pushed up, the lungs get compressed. When the lungs get compressed, it makes it harder for the patient to breathe. So when I use less gas in robotic surgery, my patient is more comfortable in that minimally invasive approach, especially when I'm doing surgeries under spinal anesthesia. Also bringing back, because I think people would want to know what's the big difference between laparoscopic and robotic surgery. That's we've dealt with all that movement business, but we talked about less gas. So less gas, Prasad, translates into less pain. Because the more you stretch the abdomen or more you stretch the tummy for the length of the duration of the operation, the more the risk of discomfort postoperatively. Also, laparoscopic equipment can do this and can do this. They can open and close and they can rotate. Robotic equipment can do this, it can do this, but the tip of the instrument has a wrist. The tip of the instrument has a wrist. That changes the game.
And I
Because,
think it does more than the human wrist
yes,
also, right? It
yeah,
can go back
yes,
I
yeah.
remember seeing that. It's like, this is a freakish movement. I mean, how do you even do that
Yeah,
with
it can
human
do
hands?
much more than the human hand can do. So because your instruments have a tip, you can imagine that if anyone had even the rudimentary understanding of physics. Now, if I put this inside and I'm doing laparoscopic surgery, you can understand that the fulcrum of the movement is the tummy wall. What that means is that all the movement that is happening of the instrument is in the region of the tummy wall. But in robotic surgery, Prasad, the tip of the instrument moves. So the movement at the tummy wall is minimal. So when patients wake up, they have less pain in their port sites when we do robotic surgery. The second most important thing is the decreased amount of blood loss. It's freakish. We do a lot of oncosurgery. I remember the times, Prasad, I think you will endorse that when we did oncosurgery, it was standard practice to have 2 bottles of blood
Yeah,
in the
absolutely.
operating theater when we were operating.
I mean, blood loss was given. You would count. I remember those horrendous signs of the nurses counting those
Not,
huge gauze pieces
yeah,
soaked in blood. How many
yeah.
gauze pieces are soaked in blood?
And you might ask, why is this blood loss so significantly less? I just told you, Prasad, that the vision is 3-dimensional, it's high definition, and it's 10 times magnified. The key word is 10 times magnified. So when I'm operating, Prasad, I'm operating very close to the tissues, and the smallest possible blood vessel looks like a big pipeline. So I secure it with my energy source even before I cut it, so that there's hardly any blood loss. So the average blood loss is about 2 or 3 tablespoons, if that, in a surgery, which is crazy to think of. Last but not the least is something which we call as the risk of conversion. Now, I'll explain that to the audience. Risk of conversion is whenever patients sign a consent form for minimally invasive surgery, there's always a caveat with minimally invasive surgery. God forbid if there is a complication, and God forbid if there is, we can't complete the procedure via the minimally invasive route, we may have to give you an incision to complete the procedure. That's a consent which is taken even before the patient undergoes an anesthesia or has the operation. So the risk of conversion, if you look at international data, Prasad, is statistically significantly less in robotic surgery as compared to conventional laparoscopic surgery. So that is also an added feather in the cap of the robotic surgical side of things.
I suddenly remembered this film, an old film called Honey, I Shrunk the Kids.
Yeah.
It's like it's like a small Imran going into patient's tummy and operating
Yeah.
from there with 10 times magnification. I can just sort of visualize that.
Yeah.
So this is amazing. I mean,
Yeah.
we have the technology which has now made us enable almost for a surgeon to go inside the patient's body,
Yeah.
see things 10 times magnified,
Yeah.
and operate it without causing practically, hardly any blood loss
Yeah.
and the side effects in terms of future.
Yeah.
So where do we go from here now? What is the next big thing coming up? What's the future like?
Uh, the future, it's very exciting, Prasad. So right now, Prasad, we are making small holes to allow those channels to allow the instruments to go in. There is another robot which is already FDA approved and people are performing surgeries abroad, which is in the US, known as single port robotic surgery. So where only one incision and the robotic arms will come inside. The whole system will go through that one incision, and smaller arms will come from inside and perform the operation with just one incision. So that's single port robotic surgery.
So
That's
instead
great.
of four
No small cuts,
incisions, you have
just one.
it's just one cut.
Just one. That's known as single port robotic surgery. Now, of course, it has limited use because they are still trying to perfect the science of doing it with such small instruments. But still, I mean, sky is the limit in terms of that. The other issue is that we are right now in India, the robots which are there, the state-of-the-art robots are what we call as fourth generation robots. Now the fifth generation robots are out with better vision, and the most amazing thing is tactile feedback. So what I mean is that surgeons, when they're holding the tissues with their instruments, will be able to feel the tissues. Can you imagine how crazy that is?
That's crazy.
Yeah, I mean, it's amazing. It's amazing. And let's not take away the fact that India is doing very well in terms of developing its own infrastructure, in terms of developing the hospitals, in terms of developing, we are leading the way in terms of, internet facilities. We will be launching 5G. That when the 5G comes in, what is going to happen is that if there are dedicated fiber optic lines between individual hospitals, Prasad, telesurgery will become a possibility. When I say telesurgery, which means I could be sitting at, say, Reliance Hospital or Saifi Hospital or Jaslok Hospital or Breach Candy Hospital, wherever you are, and you could be operating, say, on a patient in Nagpur or Aurangabad, wherever. So, I mean, so what it means is that all you need is in those areas, you will need a team to just dock the robot, and you will be able to provide expertise remotely. Now that is crazy because that's where we are heading, Prasad.
So now, I mean, I remember in the olden days, all people, everybody would have to come to big cities like Mumbai, Delhi, Chennai, Hyderabad, to access good healthcare. And now we have so many good hospitals in all parts of the country. And if you are able to do this remotely, then it even becomes better because then the patient sitting in, say, Nagpur or Akola will have the benefit of using your expertise of so many years of experience. While you are in your comfort zone, they are in their comfort zone. So that's just fantastic.
Yeah.
So this is been a very, very enriching conversation, Imran, and I'm really glad that we did this because there's so many questions even I had, we sort of got answered with these things. So first of all, thank you very much for this beautiful conversation.
It's my
And
pleasure. Oh, I haven't even touched Prasad on augmented reality and how that is going to change,
oh,
how AI is going to change the framework. It's amazing.
wow.
People think that AI will take over, but no. The doctors will still be at the epicenter of patient care, I feel. AI will contribute, Prasad, but it will not take over. So what it means is that it will create fail-safe mechanisms in place to warn the surgeons that you're entering this territory. Are you sure you want to proceed? Sort of scenario, versus taking over the surgery. So, the fear of patients that, oh my God, now robots will only operate on us. I don't think that's going to happen anytime soon. That's the key. But we are using the modern technology. Like, let's say, for instance, a patient has a CT scan and has got some issues there. You can just take all of that imagery in live surgery with augmented reality and have that image being plastered in a live scenario so that you know exactly where and how to approach it. So that's going to be the future, Prasad. And it's incredible where we are heading, and I think it is good that we are heading there because we want to continue improving patients' outcomes without compromising their functional outcomes, which I keep harping about.
So, Imran, thank you very much. For lovely having you here and having this conversation. So, yeah, perfect.
No, it's
Thank
my
you.
pleasure. It's my pleasure. Thank you so much for having me on this podcast. It was amazing to talk to you.
Thank you for joining us today. I hope you find today's episode informative. Please feel free to ask your questions in the comment section and we'll get back to you with the correct information. Please do like and subscribe to the channel, but more importantly, share this information with people you care about. Join me in this fight against cancer.